In this video, we're talking about being diagnosed with prostate cancer, and upon diagnosis, you have a high PSA and there is a lot of metastatic activity. So we're going to be talking about triple therapy and how effective it is in this situation. We're going to go through the ins and outs with Dr. Mark Schulz, who's a medical oncologist who's solely focused on prostate cancer for the last 30 years. So in today's video, we're talking about prostate cancer that has metastasized, and we need to look at triple therapy. But I think a lot of people hear this term about triple therapy and they're thinking, number one, what is it? And number two, since it is multiple treatments at once, what's the side effect profile and what will happen to me? And if I'm using treatments now, will they not be available later? So there's a lot of context and nuance to this situation that we want to go into. I think the first question I have is, can you just kind of describe your typical case of when somebody would be eligible for triple therapy?
We're talking about men who haven't been checking their PSA, show up in the medical realm with maybe some bone pain. The doctor draws a PSA and it's 500. They get a scan and it shows multiple spots in their bones. Good news is it's been researched pretty thoroughly in terms of what should you do. There's a lot of ambiguity in the prostate cancer world for treating different stages of prostate cancer, but for these men that have newly diagnosed hormone sensitive, because they've never been exposed to hormone treatment, metastatic disease, these men benefit by getting both first and second generation hormone treatment. That'd be like Lupron and Zytiga, for example, and a course of Taxotere chemotherapy. If all of this is administered up front, as opposed to piecemealing it, the temptation is, well, let's try the hormone treatment, see how far that goes. Then we'll do the second generation hormone treatment, see how far that goes. And then if we have to, we'll give the chemotherapy. Studies clearly show that the people that use the triple therapy up front will have substantially better 5-year survival by getting all this medicine in at the get-go.
One of the questions that we get in this situation is, there a particular Gleason score that is more likely to be in this situation than others. So can we just describe that Gleason 6 patients are not the ones that would be in this situation, but it's people who really have these higher grade Gleason scores?
Yeah, that's a common type of confusion that we run into in the day-to-day management of prostate cancer, is this idea that prostate cancer is one illness. And it's partly the industry's problem because they call it all prostate cancer. In the skin cancer world, we call the bad cancers melanomas. We give it a totally different name so that there's no confusion between squamous cells and basal cells, which have very low metastatic potential. In the prostate world, it's just a number, like 6, 7, or 8. The idea being that these things sort of morph together and that there's little difference, whereas the difference is as dramatic as the difference between a melanoma type of cancer. Not to imply that 8s are as bad as melanoma, but prostate cancer 8s are as different from melanoma as is grade 6 or low-grade cancer is to, say, a squamous cell or a basal cell skin cancer.
Please click that subscribe button. When you do this, it tells the YouTube algorithm that this video is helpful for you, and it'll push our videos out to other people who need them on this platform. Also, if you would like to donate to us, you can do so at pcri.org/donate. Now back to our video with Dr. Schulz. So if someone is in this situation where their PSA is high upon diagnosis and, they're going in for a PSMA scan, will triple therapy be an automatic decision if it's just, prostate cancer that's in the lymph nodes versus the bones?
No, this is a distinction that we probably should go into in some detail. The example I cited, where there's multiple spots in the bones, that's sort of a slam dunk, obvious. No one would dispute that these individuals, unless maybe they're 85 years old, you don't want to give Taxotere to an 85-year-old, but the mainstream 60, 65-year-old, elevated PSA, more than 5 metastatic lesions on the bone, pretty much universal agreement due to the quality of the studies that have been done, showing that the people that do the triple treatment will do better and live longer. As you get into early metastatic disease, say, only in the lymph nodes, you're getting into a more controversial area, and many experts are arguing that you could perhaps forego the chemotherapy because the 5 and 10 year survival rates in people that have only lymph node disease at the time of diagnosis is so good that you're not going to improve on survival rates by adding chemotherapy to it. The issue I think that gets overlooked in that equation And I don't disagree with that conclusion, that the 10-year survival rates are going to be the same. And the reason is that they'll be the same is because existing treatment is so effective without the chemotherapy. There is more to the prostate cancer world than just survival. There's also cure rates. You would think they would go together, but men can fail to be cured but still live 15 or 20 years with metastatic prostate cancer. But their quality of life won't be as good because they're probably going to be on ongoing androgen deprivation, which degrades quality of life. So being cured, which indicates that someone has undetectable or very low steady PSA with fully recovered testosterone, is possible in men that have metastatic lymph node disease. A certain number of men will be cured, maybe not the majority, only a minority. One thing that should be discussed in those individuals is whether early Taxotere is going to improve the cure rates enough to justify the potential side effects. That, I think, is something to be discussed. I think as a general rule, the policy is to forego Taxotere in the men that have only lymph node disease, at least if it's confined in the pelvic region. If someone had lymph node disease extending up into the chest or in that area, perhaps more experts would be looking at doing Taxotere. But this is a fluid situation, and I think the way I look at it is cure rates can be improved probably 10 to 15% by adding Taxotere to first and second generation hormone therapy. So if someone has, let's say, half a dozen lymph nodes in the pelvic region, which will be radiated, and hormone therapy will be administered for first and second generation for 18 to 24 months. What would the cure rate be without Taxotere in that individual? And the answer is, well, maybe 1 in 3. And could, by adding 4 injections of Taxotere over 12 weeks, improve that to maybe 1 in 2 cure rates? People have to look at how onerous the Taxotere is in terms of side effects. Some individuals might even want to try just one Taxotere treatment, see how their own metabolism reacts to it. Some men, the Taxotere doesn't bother them that much. Other men, it's pretty heavy-handed. It's not a simple black and white issue when you have lymph node only disease when you're deciding about using Taxotere.
So we talked about, possibly foregoing chemo in 85-year-olds. In the situation you're talking about now, we're talking about the average age of about 65. What about men who have been diagnosed really young at maybe 45 years old and, they have this really aggressive cancer, it's metastasized early? Would triple therapy be an automatic for them?
The value of being cured in the analysis that I just provided goes up the more years that you have to live, because the quality of life being often on intermittent hormone therapy interminably is notably degraded. And if there's an opportunity to take just 4 injections, some say 6 injections of Taxotere, and cross over from disease control into disease cure, where you never have to take hormone treatment again, is a very attractive proposition. The problem with this analysis, as I'm presenting it, there haven't been any studies that have really nailed down how much the cure rate goes up with Taxotere in this setting. But you can look indirectly at studies and estimate that it's probably in the 10 to 15% range in terms of improving cure rate. So the process is, as I described, to first do an analysis based on your own Gleason score, how high the PSA is, how many lymph nodes are present, and make a judgment of what the cure rate would be with only first and second generation hormone therapy and radiation to all sites of disease. So if someone has just one lymph node and their Gleason score isn't that high, their cure rate with all treatment and not using Taxotere would perhaps be 30 or 40%, and that person may want to try and push the cure rates up a little bit if they're very young.
So as far as these treatments go, can we get a little more descriptive on the side effects? Because I think that there's a large concern from the patient and from the caregivers that if they're going to be taking all of these in combination, that the side effect profile and toxicity would be very intense. So we know with hormone therapy, first and second generation, that the side effects are the same, kind of. Can you describe them for us?
Right. So it's not a difficult decision to add second generation hormone therapy. As of 2024, the studies are very clear that the efficacy of the hormone treatment is enhanced substantially by adding a second generation agent such as Nubeqa, Xtandi, Erleada, or Zytiga to a first generation agent such as Orgovyx, Lupron, Zoladex, Trelstar, and others. Therefore, that decision is very easy. Sometimes cost could come into play, but Zytiga is generic now and it should be affordable. The decision, however, for adding Taxotere is a more notable one. In men that can have radiation treatment to all sites of disease, have oligometastatic disease, I think that is sort of a no-brainer because with quality radiation these days, the side effects should be very, very, very manageable. So it's really the decision about adding Taxotere chemotherapy that becomes problematic. And chemotherapy is chemotherapy. People have hair loss. The most problematic issue is that there's about 5 to 7 days of feeling fluey and tired and achy after each injection. These injections are given every 3 weeks. And with each successive infusion, the side effects tend to become more prominent. And this is why many times we suggest stopping after 4 treatments rather than giving 6. So it's a fairly big undertaking. When you talk to men that have been through it, and I've talked to many, and just how 6 months later, how bad was it? Pretty intense is the description, and they're very glad that it's over. Most people get through it pretty nicely. There certainly can be hair loss. The nausea problems have been solved with anti-nausea medicines, and there's some other things that can happen rarely, but for the most part, it's very prominent fatigue, which if people are not diligently pursuing an exercise program, they can already be a fatigue from the hormone treatment and even from the radiation. So to add a third leg of more fatigue is a daunting prospect if you're not really prepared to compensate with a rigorous exercise program.
Talking about the timing of all this, how quickly from somebody coming in, getting a PSMA scan and showing that they do have widespread disease and needing triple therapy, are they going to get these treatments? Which one comes first and in what time frame?
With the hormone blockade medicines, it becomes a very simple proposition. Most men, once the staging is completed, they'll start on first and second generation hormone therapy. That'll put the disease in a rapid reverse. If you go back 15, 20 years, that we use that as standalone treatment in these men, and they do very well. So that then buys you time to think about these other decisions, such as doing radiation or doing Taxotere. Timing of the radiation or the Taxotere probably doesn't really matter. You can do it 1 to 2 months after diagnosis, 6 months after diagnosis, because the typical time frame for the PSA to drop from the starting point, let's say the PSA was 300 when you started it off, to all the way down to 0.1 or less is usually a 4 to 6 month time period for that hormone treatment to lower the PSA all the way down to where it's going to go. The radiation is typically given first if that's going to be done because that's a more standard agreed upon methodology. It doesn't have to be. Taxotere could be given first. Radiation and Taxotere are not given at the same time. They're given sequentially. Basically, the situation is very flexible.
And as far as duration goes, what is the typical time frame of these patients being on hormone therapy?
I would say that the consensus for people with metastatic disease is to be on treatment, hormone deprivation, testosterone deprivation for about 2 years. The shorter interval of 18 months is sometimes talked about, and then there's some that would argue for even 3 years of treatment, which in my mind seems excessive. This is all assuming that the undetectable PSA has been achieved with treatment and the PSA is controlled less than 0.1. There are some individuals who are newly diagnosed with these high levels of metastatic disease that are going to struggle to get their PSA down to less than 0.1. Be a minority of the patients, but it happens. And in those people, we're not recommending stopping treatment.
With the advent of PSMA and us being able to watch what's happening in the body at a pretty sensitive degree when it comes to prostate cancer, is there a way to lessen hormone therapy because of that within the situation of triple therapy?
No, I don't think so. I think that the utility of a PET scan is significant, and if the PSA is undetectable, I think makes sense to get a PET scan to make sure there's no visible disease before stopping hormone treatment. And this is often a thinking in the minds of patients as well. Well, the PSA is down to 0. I'm not getting any further value out of the hormone treatment. Can I stop it early? And the studies indicate that no, you can't. There are things going on below the threshold, below the radar, that are meaningful, and there is an ongoing benefit of the hormone treatment going beyond 6 or 12 months. And I think the same thing would be said for PET scans too, that there really, in most cases, isn't much use for doing PET scans when the PSA is less than 0.1. You're not typically going to be seeing anything. But I can understand it as a form of insurance for men that have, started off with a PSA of 300, and thankfully their PSA is undetectable now, and they're thinking about stopping hormone treatment after a couple of years to get a PET scan and just make sure that everything is, even just as a baseline, to make sure everything's completely gone.
So I just like to clarify, when we talk about chemotherapy in prostate cancer, there's the media and movies and things that we watch. You watch these people go through chemos and other diseases, and it's very, very intense. And I'm not saying it's not intense in prostate cancer, but can you talk about how the chemos in prostate cancer affect men and kind of the differences between mainstream chemos that we see in other diseases?
So Taxotere, or Jevtana, which is a medicine very similar to Taxotere, it's kind of nice to talk about these as medicines rather than chemotherapy, because chemotherapy for other diseases like breast cancer, lung cancer, liver cancer, colon cancer, almost invariably involves combinations of multiple chemotherapy agents given simultaneously. As you can imagine, that's going to tend to have a lot more side effects than just one medicine given, even in somewhat attenuated doses. The amount of Taxotere that's given to a prostate cancer patient usually is less. The recommended dose for prostate cancer patients is less than what the recommended dose is for Taxotere, say, in lung cancer or breast cancer. There's an incredible variety of what chemotherapy is, and the memorable things when we hear about radiation or chemotherapy or the word cancer is always the really bad things that make the headlines. People can get through Taxotere pretty easily, if we limit it to 4 injections, an injection every 3 weeks. There are ice caps that can prevent hair loss, so you don't have to go through the indignity of hair loss. Considering that the overall cure rates for some of these men, although the cure rates may be relatively low with or without chemotherapy, they are higher with chemo than they are without. So again, making that distinction between cure rates and control or survival. Men are going to survive a long time with prostate cancer, but the advantages of a cure are better quality of life, so you never have to go back on the hormone treatment again. It's a roll of the dice. There's going to be a lot of people that go through the Taxotere and don't get cured. Some of them may end up with longer remissions than they otherwise would have. If people aren't cured after this whole treatment has been administered, let's say you've had hormone therapy for 2 years, stop, testosterone recovers, and 2 years after that, your PSA starts rising, and you get a PET scan, and you start looking for where the problem is, you radiate it, get further therapy. That remission period after the testosterone recovers quite likely is longer in the people that have had Taxotere. So it pushes that time for relapse out in some individuals. So you have longer remissions, you have higher cure rates, but it does come at a cost, and it is at a time when you're already going through a lot of other treatments. So it's not an easy undertaking, but it's manageable.
So, you mentioned that if the PSA does rise in this situation, you can go back on hormone therapy, you can talk about radiating again. So it sounds like with hormone therapy, radiation, and, maybe with chemo, they can do it as a treatment later in life if the cancer does come back. Is that true in all 3 categories?
It is. The old problem we had where people said you can't re-radiate in something that was previously radiated lingers in the air, because that was a big problem in the era where radiation doses were suboptimal. And so they would radiate the prostate, and then the disease would come back in the prostate, and now what do you do? That used to be a big problem. With modern radiation, the doses are now intense enough to almost guarantee that sort of thing's not going to happen. So if a cancer recurrence happens down the line, it's in a different area of the body that can be radiated. So yes, all these things can be reused at a later date if necessary. And you could see how some people in doing this analysis might say, well, I'll do the hormone therapy now, I'll do the radiation now. Let's say I only have lymph node metastasis. And if I'm facing this again someday, maybe I'll do the Taxotere at that juncture, or maybe they'll have a better treatment for me at sometime in the future that will be invented. These sorts of analyses are all very sensible to think through as one is considering whether or not to add the Taxotere to the mix.
One of the situations that we're seeing in the comment section of our videos or the helpline is that we have a lot of patients who are watching internationally. And we have a lot of patients where they're coming in kind of either rural areas or what we call community settings. Maybe they don't have a large university or something near them. And they have these really high PSAs upon diagnosis, and they're going into these triple therapy situations. So, We talk about in other videos with different procedures about really making sure you're going to a center of excellence. But it sounds like with hormone therapy and chemo, those are pretty standard treatments. With the radiation, what type of radiation are they using? And do you need to go to what we call a center of excellence or somebody who's done this a lot and is doing these studies? Or is this type of radiation pretty standard in a community setting can be effective?
There is skill in minimizing the side effects from giving hormone therapy and minimizing the side effects from giving Taxotere. However, the side effects from those things are more reversible. If someone's giving you suboptimal care, you'll probably get through it, and you probably won't be left with permanent results from suboptimally managed hormone therapy or chemotherapy. It's not desirable, but you'll probably get through. Suboptimally administered radiation can be a permanent problem for the rest of your life. If something gets burned that's not going to heal because of poorly administered radiation, that is a much higher stakes issue. I think that when facing a decision like this, if people have an opportunity to seek out a large center that has a lot of experience, has up-to-date equipment, that they're much more likely to be happy with a long-term outcome.
There are some key factors that are very important through our discussion today that I realized. So the first one being that you really want to make sure you have a medical team that is working with you. You want to make sure that they are answering your questions, they're not just brushing you off, and they are communicating well with you. Because the second thing that, factor that's really important is you're going to go through a lot of side effects, and you want to be able to communicate those side effects to your medical team and for them to help you, mitigate them, deal with them in a timely manner. And so it's important that you feel like you have a support system through your medical team, maybe through a caregiver, whether that's a partner or through a child that is, helping take care of you, or maybe it's some friends or a support group. I would really encourage you that in these situations, there are so many things that you as a prostate cancer patient are dealing with. The financial toxicity, the, deciding upon treatment, the ins and outs of having to even travel and go back and forth between these appointments, the anxiety, just even the idea of having cancer, the way it affects you on a day-to-day level and the way you feel. There's just so many factors that when people talk about prostate cancer, they're not you. They don't realize everything you're going through. And it is very important that we try to take care of your quality of life because you're already going through so much. And quality of life in this situation, you may say, well, the cancer is widespread. Why are we focusing so much on quality of life if we really need to work on getting this disease under control? Well, you need to focus on both, because even the process of what you're going through as you're getting the disease under control matters. And we want to make sure that you're taking care of your mental health, your emotional health, and really trying to mitigate these side effects to the best possible way so that your quality of life can be the best it can be. So please, I know we talk about weightlifting on this channel, and it's very difficult to weightlift in this situation, but the studies have shown that weightlifting not only can help you get through the treatments a lot easier, but also it can help with the fatigue almost to an 80% level in fatigue reduction. And that's really important. So, if you can maybe go to a class or get a trainer, pretty soon we're going to be releasing a program that just shows you, simple moves that you can do without a trainer, just with some weights at home in a safe way so that you can start to build up muscle mass. These types of things have shown to be effective, especially in hormone therapy, in radiation, and in chemo, and it'll help your longevity overall. We want to make sure that you go through this whole process in the best way possible, and definitely lifting weights and, paying attention to who you are as a person and what your needs are is very important. So please communicate what those needs are. Please remember that you're not alone. You're very important. We care about you. If you need help, getting your questions together for your medical team, or you need just more information about anything that we discussed today, you can contact our helpline at pcri.org/helpline. These are prostate cancer patients who've been trained by our medical oncology team, and they're going to give you information, not advice, but they really help you cultivate your conversations with your doctor and really help you focus on getting the best outcomes. If you would like more information about anything we talked about, you can also go to pcri.org. We really appreciate that you watch our videos. Please leave any questions or topics you would like us to cover in the comment section below this video. I hope you have a great week, and thank you for watching.